Hilary.
Hi everyone. So yeah, I'm Hilary. I work with Vicky at the Old School Surgery. So I'm the mental health nurse team lead over here. So I've done a presentation today about sort of, I guess, common mental health problems that we would see within primary care. So if I go on to just some learning objectives. So yeah, to think about some common mental health problems, look at treatment pathways, and also to discuss sort of serious mental illness reviews, because I know sort of a lot of you are maybe doing those at the minute. I'm happy if anyone wants to ask any questions. I'm really not very good with technology, but I will try and do my best if people want to like put the hand up or whatever. But at the end, if there's any questions as well, happy to kind of go through them. So up to you guys, whatever you prefer. So I thought I'd start off with depression. So depression is the sort of so mixed anxiety and depression is the most common mental illness within the UK, and I think in the world as well. So some common symptoms of that would be things like low mood, obviously, is the kind of main one that people would see most often. So feeling just very low, not being able to feel happy. Anhedonia as well. So anhedonia is the sort of inability to be able to experience joy. So not kind of finding interest, not being able to enjoy things particularly things that you've previously enjoyed. Changes to appetite and sleep disturbance are two of the other common ones. So that could go either way. That could be increased appetite or decreased appetite. And that could be kind of hypersomnia, so oversleeping or not getting enough sleep, not feeling able to sleep. Poor motivation and concentration are the other two kind of big ones, really. So you speak to people often who will just not feel that they're able to kind of do normal day-to-day things. So things like getting up, brushing their teeth, having a shower, those sorts of things. And we would say that kind of depression would be, you would sort of be able to think about that as a diagnosis if these symptoms have been present for sort of most days within sort of longer than a 2-week period. And with depression, that can be sort of mild, moderate or severe. So lots of people that we see in primary care, that might be kind of mild depression, and people might be presenting for the first time. I think I put something on there, any given week in England, 3 in 100 people will experience depression. So it is sort of quite common. I guess within primary care, what we would be really encouraging people to do is to be thinking about self-help. So directing to sort of self-help resources, thinking lots about lifestyle advice. So encouraging regular exercise, making sure that they're looking after their sleep. So sleep hygiene is a big thing as well. Thinking about drug and alcohol use, making sure that they're not kind of, if you're not feeling great, not to be using drugs and alcohol, because that's likely to impact on that. And then also to think about sort of cognitive behavioural therapy, often sort of either self-guided or low intensity if people are presenting with mild depression. If it's more sort of moderate or severe, you might think about kind of more high intensity CBT. And then there's also obviously antidepressants if we were thinking about medication. In primary care, we would kind of recommend the lifestyle and CBT things first. So antidepressants would be sort of second line, particularly for mild depression. We wouldn't kind of think about that in the first instance. More moderate or severe, you could recommend that, but you would probably recommend that alongside the kind of lifestyle advice and CBT stuff as well. So yeah, does anyone have sort of any questions, or happy for me to kind of go on to the next thing and we can pick up on stuff at the end? Up to you guys.
I think we're just happy to go ahead.
Yeah, lovely. All right, on to the next one. So next thing to talk about would be anxiety. So anxiety it's a natural human response. So it's that, you probably have heard before, it's that kind of fight, flight or freeze. So it's kind of there from when we were cavemen, and we would have to either be sort of escaping from danger or fighting danger. So it's a really normal emotion, really normal reaction, and often can be quite helpful. So often, we'd think about things like if you've got a deadline at work, or if you have got, you need to get your dissertation written for uni, those sorts of things. It's really helpful to have some anxiety because it's kind of spurs you on to get it done. I guess when it becomes an issue is when it tips over into people not being able to kind of function. So that instead of it sort of being good stress, it then tips over into, you know, not being able to do the things you need to do, finding it difficult to socialise, finding it difficult to kind of get into work, those sorts of things. So generalised anxiety disorder, there's lots of different types of anxiety. So I've listed a few on there. I won't go through all of them. I guess the kind of most common that we would see would be generalised anxiety disorder. So that is sort of characterised by restlessness. So people feeling sort of fidgety, not being able to sit still, also struggling with kind of feeling on edge. So people will often describe this sort of impending sense of doom. So this feeling that something really bad is going to happen, and often not being able to put their finger on like what that might be. So for some people, there might be specific things that they worry about. For some people, it might just be this general feeling of being on edge. People can also struggle with concentration. So that's like a particularly kind of common thing that you see when people are anxious, is sort of not being able to focus on one thing, or not being able to focus on something for very long, because they're often sort of distracted by the overthinking, so the ruminating the thoughts that they're having. People can also get quite irritable, so you see that quite often, people just getting, you know, having quite a short temper, or feeling like they're sort of losing their temper quite quickly with people. You know, often people will say, you know, like, you know, my children, that I'm not able to kind of, not able to sort of hold my temper for as long as I usually would be able to. And then also sleep disturbance as well is another one. So yeah, again, often people kind of report not being able to sleep at night because they're ruminating, they're overthinking on things, or they're waking up in the night and then feeling worried about things and not being able to go back to sleep. Muscle tension, so that's another one as well. So often when people are feeling anxious, they will maybe carry that somewhere in their body. So people might describe having sort of really tight shoulders, having a tight chest. Sometimes people describe having sort of jaw tension as well, so that really stiff kind of gritted jaw. And we would sort of be able to think about a diagnosis of anxiety if those symptoms have been present for sort of longer than a 6-month period, and for sort of most days. In any given week, 6 in 100 people will report experiencing generalised anxiety disorder. And so there's a step care treatment plan as well, which is available if you go on the NICE guidelines. It's kind of set out there. So it would be sort of initially low intensity CBT or guided self-help. Also psycho-educational groups as well, to sort of explain anxiety, the role of the kind of cycle of avoidance as well. If people don't kind of get on with that, or if it is kind of more if it is more severe, then you could think about, again, SSRIs, so selective serotonin reuptake inhibitors. That's things like sertraline, citalopram, those sorts of things, or an SNRI, which would be like duloxetine or venlafaxine, to think about if people needed some medication, and also to have that alongside the high intensity CBT. So a few different types of anxiety I put down there. Like I said, I won't go through all of them, but I guess the most common ones that we would see in primary care is, particularly in our practice, we work with a lot of students, so there's a lot of social anxiety disorder, so people feeling very, very anxious about social situations, interacting with peers, that sort of thing. OCD as well, so obsessive compulsive disorder, which is kind of, that's when people have sort of either or both kind of compulsions or intrusive thoughts that they find really difficult to manage. And again, treatment for that would be sort of CBT based psychological intervention, or SSRI, SNRI for medication. So next, okay, so ADHD. So I think this is sort of lots of stuff recently, probably over the last couple of years, about kind of TikTok. I'm not sure if there was a something on Netflix about that as well, but there's been with social media, there's been quite a sort of upward trend in people seeking an ADHD diagnosis. Lots of people kind of seeing things on social media and then relating to symptoms. So we've seen quite a big increase in people kind of looking for a diagnosis, looking for an assessment. So ADHD is attention deficit hyperactivity disorder. So there's kind of two sides of it. There's the inattention side of it and then the hyperactivity side of it. I think it's actually for women, it's kind of lots more women who are seeking a diagnosis in adulthood are more likely to just have the ADD side of things, so more the deficit rather than the hyperactivity. But with the ADHD, it would be 5 out of 9 symptoms of either of the inattention or the hyperactivity, which would allow you to kind of formulate a diagnosis. So inattention is things like poor concentration, misplacing things, being bad at time management, procrastinating, putting things off. And then the hyperactivity side of things, fidgeting, not being able to sit still, feeling like you're sort of driven by a motor, excessive talking, interrupting, difficulty waiting, all of those sorts of things. As it stands, to kind of have an adult diagnosis of ADHD, those symptoms must have been present in childhood. So it's very uncommon for people to kind of develop ADHD if those symptoms haven't been there since they were younger. We don't diagnose ADHD in primary care. That has to be done by a specialist service. So there's a couple of sort of routes to that. There's the NHS service in Bristol or the Right to Choose service. The NHS waiting list is really long at the moment. It's about 4.5 years. So they set up the kind of Right to Choose service to try and tackle some of that backlog. Although because there's such a high demand for the service, I think the waiting list for that at the moment is also fairly long, probably sitting about a year. And it's obviously, you know, patient choice as to which one they would prefer to be referred through. And then it's up to the specialist service. They would make they would do an assessment, make a decision on diagnosis, and then they provide treatment and stabilise people within secondary care services before they come back to the GP for prescribing. So a couple of options for sort of ADHD treatment as well. So ADHD coaching is the sort of psychological intervention. So people can access that privately as well, and you don't necessarily need to have a diagnosis to start accessing that. I think there's also some apps as well, which are, you can kind of pay for, and you can have that sort of guided coaching. And then also stimulant and non-stimulant medication, so things like Elvance, methylphenidate. They're all controlled drugs, so again, that's why they need to be sort of prescribed by a specialist practitioner. And we can't just give those out in primary care. And then there's quite strict rules around, if we take over shared care prescribing, there's quite strict rules around sort of monitoring and then the patient needing to be seen sort of yearly for a review. We have started doing annual reviews for ADHD medication in primary care, but that's only with the adult ADHD service. Psychiatry UK, who has the contract for the Right to Choose, they will do all of their own annual reviews. Yeah, so that's ADHD. Next kind of one that we see quite a lot of would be eating disorders. So yeah, between 1.25 3.4 million people are affected by an eating disorder. So the kind of common ones would be anorexia, nervosa, bulimia, and binge eating disorder. So common symptoms there's kind of crossover between the different types. I guess anorexia, that would be restricting food and fluid intake, preoccupation with weight and image. So having this very fixed belief about kind of weight, often which doesn't sort of marry up to what's actually going on in reality. Inappropriate use of laxatives, fasting, excessive exercise. With bulimia, there might be those symptoms, but there would also be the sort of purging as well. So yeah, kind of vomiting after meals. Binge eating, again, that's when people really struggle to kind of control how much they're eating. So anorexia and bulimia treatment is offered through the NHS. So it's the STEPS team, who is the NHS service. They offer different psychological interventions. So binge eating disorder, unfortunately, there isn't a provision for that within the NHS. So there's some guided self-help information available, kind of directing people towards private treatment, but there is a gap in service provision for that which is really unfortunate because, again, it is a, it's a recognised mental health disorder. People should be able to access treatment for that. The thing that when we get involved in primary care is we're thinking about monitoring people's physical health. So often people with sort of particularly significant eating disorders, you would be really worried about kind of different physical health problems. So it kind of depends, and that's usually done in conjunction with steps, but we would be looking to be doing people's weight and also, blood pressure, heart rate, things like that, and a BMI pretty regularly. Also, sometimes people's bloods can be sort of quite deranged. You need to keep an eye on that, and that's something that a GP would be following up on as well. So it kind of depends from person to person. So some people that might be kind of 2 weekly physical health monitoring, or for some people that might go to monthly. And again, with eating disorders, the kind of severity can often fluctuate. So sometimes people may be going through a sort of worse stage than at other times. And so the physical health monitoring should be kind of changed to reflect on that. So the next one. So personality disorders. So yeah, personality disorders. So around 1 in 20 people in the UK have a personality disorder. Historically, the personality disorders were kind of clustered into A, B, or C. So A was the kind of schizotypal. B was it's sort of the borderline or emotionally unstable, antisocial, narcissistic, and then C was the more kind of anxious end of things. So there's been a change recently. So the ICD-11 is a classification system which is used in the UK for mental health problems, and it's kind of been changed now to sort of general personality disorder, and that is split into mild, moderate, and severe. I guess because borderline personality disorder is kind of the one that comes up most and the thing that we see most of, in the new ICD classification, there is a kind of subsection sort of as a borderline personality trait. So that's the one that I'm going to sort of focus on today. There's, you do see other, different types of personality disorder, which are kind of, very interesting. And but I guess because we've moved away from that, I thought I'd just focus today on the borderline personality, which is probably kind of, we would see most in primary care as well. It's those sort of, we always talk to patients about kind of personality disorder versus personality traits, because a lot of the traits are present in lots of people, but a borderline personality disorder would take quite a number of years to kind of think about and diagnose. So the main kind of symptoms would be fear of abandonment. So that's a really big one. So people having often quite unstable relationships due to this fear of being abandoned. And there's, lots of schools of thought about why that is. One of them is this sort of biopsychosocial model. So where people, have difficult attachment styles in their childhood and their formative years, and how that kind of affects people later in life. Also having a really unstable sense of self. So people often describe just like not really knowing who they are, or not feeling like they're able to sort of enjoy things, or not feeling like they're able to connect with people. So yeah, describing this sort of idea of, if they meet someone new, they meet a new friend, then that might mean that they start doing all the same hobbies as this friend, or they have all the same interests as this friend, because they don't know in themselves what it is that they like or what it is that they enjoy. There could also be like a lot of impulsivity, so particularly with borderline personality disorder associated with kind of suicidal behaviours and self-harm. Chronic emptiness as well. So yeah, that like I said before, that feeling of not really knowing who you are and just feeling quite empty and not really knowing what's going on for you. There can also be sort of transient or stress-related paranoia. So some people describe sort of voice hearing or paranoid thoughts about friends or family. It's kind of lower level than psychosis, and sometimes the sort of voice hearing can be described as having this internal monologue. So yeah, and then that can also kind of be coupled with disassociation as well. So depersonalization or derealization, so not kind of feeling connected to the world or feeling that you're not sort of a part of the world. So yeah, traits versus disorder. So lots of people can have traits without actually having a sort of diagnosis. The kind of evidence-based treatment would be dialectical behavior therapy, psychodynamic psychotherapy, structured clinical management. So structured clinical management, secondary care provide that. Dialectical behaviour therapy is available through secondary care, but there is a real gap in service provision, so it's very difficult for people to access that. It's also dialectical behaviour therapy is a sort of in its purest form. You would be having group sessions once a week and a one-to-one session with a private therapist once a week, and coaching on the phone if you were kind of needing to access support to manage distress. And generally those, you know, they would last for kind of anything from a year to 18 months, the courses. So it's not a treatment which is really widely available on the NHS, because it obviously requires a massive amount of funding to be able to do that. There is some private providers who offer it, but again, that's really, really expensive. And a lot of our patients who are going to be experiencing these type of symptoms are not going to be in a position where they're going to be able to afford that financially. So there isn't a medication which is licensed for use to treat personality disorders. So you can use things to treat comorbid symptoms. So you could use an antidepressant to treat anxiety or low mood. You could use potentially a mood stabilizer to think about that kind of emotional dysregulation side of things, although that's not really very commonly done either. Often with personality disorders, you see quite frequent presentations. So there'll be people who pop up on the GP triage list quite a lot, or will have sort of ongoing appointments. Lots of the work that we do in primary care would be around safety planning. So making sure that people feel safe if they are having those sort of distressing thoughts. As mental health nurses here, we would do sort of brief interventions with people as well. So thinking about some distress tolerance techniques. And also a lot of work in primary care is kind of that validation side of things as well. So sort of recognizing that actually it's really difficult to live with those symptoms and it makes things really hard. And actually the fact that they're sort of reaching out for help is really important. And also reducing stigma as well. Historically, borderline personality disorder has been a diagnosis that comes with a lot of stigma, and often that means that sort of other symptoms or comorbid things are not taken seriously. So people sort of see somebody with a personality disorder diagnosis and then may not treat other sort of either physical or mental health problems in the same way that they would do for more of the general population. So yeah, trying to sort of reduce that is helpful. One of the things with personality disorder as well, which is kind of from a clinician point of view, is this idea of countertransference, which I just thought I'd pop in here because I think it's quite interesting and good to reflect, particularly if you're working with somebody who you are kind of getting countertransference from. I think that's always, for me, a really something that I always kind of reflect on and think about. So countertransference is this idea that you might be working with somebody and then you feel sort of irritated or annoyed, or they bring out an emotion in you which you're not really sure why that is there, but you're then kind of putting that back onto the patient rather than kind of taking a step back and thinking, actually, what is happening for this patient that is making them behave in this way. So yeah, countertransference is that idea of how someone else's behaviour affects you. So I think that's always good to reflect on when you're working with people who have a personality disorder. So next, what have we got? Okay, yeah, so severe and enduring mental health conditions. So when we're talking about severe and enduring mental health, this is the sort of people we would be thinking about when we're thinking about SMIs. So the main kind of severe and enduring mental health are schizophrenia. So schizophrenia is, often people, there's not a particularly good recovery rate. People might go into remission, but often if people have schizophrenia, that's going to be something that's sort of lifelong, and are probably going to need some form of treatment for that throughout the rest of their lives. So positive symptoms of schizophrenia are hallucinations, so hearing voices, any sort of perceptual disturbance, so any alteration of reality, really. So that might be people seeing things, might be people tasting things, might be people hearing things that can't be heard by other people. Disorganized thinking or thought disorder as well, so being very tangential, going around in a conversation, not really being able to get to the point where they want to get to. Also some sort of quite interesting different ones, things like echolalia. So that's where somebody would just repeat back, and it's a kind of, it might be a word, it might be a phrase, it might be what you say, but they would just kind of continue to repeat that back to you. So that is kind of one form of thought disorder. There's lots of other different ones. So yeah, that obviously can be really distressing for people, particularly when with hallucinations, people can have quite quite unpleasant things that they're hearing. And the other one that we would sort of be really worried about if people were having an episode of psychosis would be command hallucinations. So that would be sort of voices telling them to hurt themselves or to hurt other people. So that's a really important thing to be checking in with if you're working with somebody who has diagnosis of schizophrenia or who has experienced psychosis. Negative symptoms would be things like lack of motivation, anhedonia, poor hygiene, grooming, poverty of speech, change in behaviour, and sometimes cognitive impairment as well. So sort of can be quite similar, can look quite similar to a depression. So yeah, can check in about stuff for that. For a first episode of psychosis, we'd refer on to the early intervention team. So they're a team that can work with people for I think up to 2 years from their first episode, and then they will either refer on to the recovery team if they're needing longer term work, or can be discharged back to the GP if symptoms are in remission. Treatment would be sort of antipsychotic medication, so things like sort of olanzapine, risperidone, aripiprazole. They're the kind of newer generation of antipsychotics. And then you've got like the older ones, which are things like haloperidol and Pixar and things like that, which are sort of, oh sorry, not Pixar, it's a newer generation one, which are not, the kind of older ones are not used so much anymore. They tend to have more side effects. So that when we're talking about, I guess, side effects of antipsychotic medication, the older generation, it would be they're called extrapyramidal side effects, so EPSEs. So that can be things like apaesthesia, so a sort of internal sense of restlessness. It can be Parkinsonism type symptoms, so sort of shaking. People can also get sort of muscle rigidity. There can be, lots of kind of difficulties with that, and that's why the move was away from those. With the newer generation antipsychotic medications, things like olanzapine, there's less risk of having the EPSEs, but there is more risk for like metabolic symptoms, so weight gain, kind of leading to diabetes, things like that. So again, they're all medications which should be monitored, and that's part of the SMI really, for people on antipsychotic medication. Bipolar disorder, so depression, kind of similar to depression that we talked about before, can look pretty similar. And then the other side of that would be manic symptoms. So that's often overspending, feeling like you have lots of energy, decreased need for sleep, sometimes sexual promiscuity as well, or risk taking, people doing things impulsively that they wouldn't do. There's type 1, type 2, there's a few different types. The main is sort of type 1, and that would be your classic, what used to be called sort of manic depressive. So kind of really clear periods of mania and then really clear periods of depression. Type 2 is sort of hypomania, so not really getting to that manic stage, but having those symptoms on a kind of lower level. Cyclothymia is more of a rapid cycling, so that would be people kind of going through those stages, but kind of within a day or within a few hours. So treatment, we would be referring on for further assessment within secondary care if we were suspecting a bipolar affective disorder. One of the reasons for that is because if somebody is having a depression in primary care, like we said before, we'd maybe prescribe an antidepressant. If you prescribe an antidepressant to someone who has a bipolar spectrum disorder, there is the potential that that could put them into a manic phase. So that, again, that just needs to be assessed by secondary care, by specialist service. Psychological interventions, so CBT, interpersonal therapy, and there's also kind of mood stabilizer treatment medication, so lithium, sodium valproate, but again, they would only be started in secondary care and then back to primary care once they're stabilized. So SMI review, so I guess that's, you guys have been doing amazing work sorting all these out, and Vicky's certainly been doing loads of great work for us, which is amazing. So yeah, there's a well-evidenced health inequality between the general population and people with an SMI. So people with a serious mental illness in England on average die 15 to 20 years earlier than the general population. So obviously a big need to kind of think about how you sort of reduce that gap. People with an SMI also have a higher prevalence of obesity, asthma, diabetes, COPD, stroke. So there's a few reasons for that, I guess. One of them is, I'm not sure if you guys have ever heard of the sort of ACEs study, so adverse childhood events. So there was a study done which looked at adverse childhood events and the impact that they had on sort of people's health, so physical health and mental health. So lots of people with adverse, more than one or two adverse childhood events will have poor outcomes for physical health and for mental health. Also, people with a serious mental illness are maybe less likely to be thinking about self-care. So again, kind of obesity, smoking, and all of those associated problems are probably going to be more likely for people in that population. And again, with schizophrenia, we're talking about the negative symptoms, so people having that really low energy, anhedonia, not being able to do the things that they kind of need to do, so being less active. Again, that can all have an effect. So with the SMI reviews, part 1 is the annual physical health checks, so BMI, blood pressure, pulse, rests, HbA1c and lipids. So yeah, we book people in for those. And then schizophrenia and all patients who are on antipsychotic medication should also have electrolytes, urea, full blood count and LFTs done. And this is just because of that metabolic stuff that I was talking about with the newer generation antipsychotics. So that's why we would be checking all of those things. And ideally, we would want them to have an ECG as well, because antipsychotic medication can have a effect on your QT interval prolongation. So yeah, cardiac monitoring should be done as well. If you have bipolar, then we should also include LFT, renal and thyroid function, and calcium levels for patients who are taking lithium. And people who are on lithium will have kind of bloods done periodically anyway throughout the year. Part 2 of the annual mental health review, so that's the bits that, like in our surgery, the mental health nurses would do that. So that would be to check on kind of mental health symptoms, do a medication review, think about physical activity, diet, alcohol, smoking, recreational drugs, accommodation, employment, basically all of that psychosocial stuff that's going on. Think about whether there's any kind of secondary care involvement, thinking about what the services it might be helpful to get involved, and safety planning as well. So always kind of doing that risk assessment. So I thought I'd just put this bit in here. So acute stress reaction. So this is the stress vulnerability model, this little model that you can see here, that was created in the 70s. So it basically is a really kind of basic thing that we use to, like in a lot of psychoeducation for patients, about basically stress and vulnerability. And if your stress increases, you're going to be more vulnerable to poor mental health. So psychosocial adversity can cause mental distress, and this may or may not develop into mental health disorders. So if we're thinking about acute stressors, that could be things like bereavement, so loss of a loved one, job loss, eviction, relationship breakdown, thinking about ones in primary care that kind of come up as well, people having their children taken away from them, things like that. So those kind of acute stresses, I guess, can be things that people might lose their job, and actually that might mean that they feel very low, or they feel very depressed, or they feel very anxious for a period of time. Then they might get a new job and that might go away, and there might not be any need for kind of sort of mental health treatment as such. There's also things like recurrent stresses. So that would be drug and alcohol misuse, abuse, domestic violence, and then chronic stresses, poverty, accommodation, long-term physical health conditions. So they all have an impact on people's stress, essentially. Often what we do when we're working with people who are having those acute stress reactions, a lot of the mental health nurse role here would be to look at what is causing that, and actually is there something that we can do to alleviate that stress before it tips over into kind of a longer term mental health condition. Okay, so yeah, this is the kind of you've probably seen this before, so the 5 ways to well-being. So I thought I'd just add that in at the end. So this is kind of, I think, just good advice for anyone really who's wanting to take care of their mental health. So thinking about kind of connecting with people, so that's a really good one. So talk and listen, be there for other people, but also make sure that you've got that support yourself so that you feel connected. So that's one of the really big things with mental health, is making sure that you've got your own support network around you. Being active as well. So there's loads of evidence, loads of studies which show that kind of increased activity means kind of more positive outcomes for mental health. And that's across the board for anything from schizophrenia to depression. So yeah, thinking, and also thinking, I often, have conversations with patients who are like, I don't know what, I've never been to a gym before. I don't know what I like. I don't enjoy exercise. And I think exercise is so broad. There's so many different ways that you can exercise. It's sometimes just about having that conversation with somebody and thinking about what's going to work for them. So yeah, whether that's sort of wild swimming or, walking around to the shop every morning to get a pint of milk, anything that person can do to become more active. I think that's just often a really kind of underutilized way of thinking about promoting good mental health. So it's that one. So taking notice, so remembering simple things that give you joy. So thinking about just the little things, and so sometimes that might be just having a conversation with someone about, every day, just think of 3 things which have made you happy, or think of 3 good things that have happened. And then keep learning, so embrace new experiences, see opportunities, surprise yourself. Yeah, so just thinking about, doing new things that are going to make you happy, sort of broadening your horizons. And often that comes with connecting as well. So thinking about, is there things that you can be doing with other people that are going to be good. And then giving, so your time, your words, your presence. So yeah, again, lots of evidence to show that if you feel that you're helping other people, that's going to give you a kind of more positive sense of your own sort of mental health as well. So that information is all available on the NHS as well. The NHS website's got a lot of information about that. And that's the end of my presentation. So does anyone have any questions? Anything they want to talk about? Should I stop sharing this bit?
I had a couple of questions if no one else did. I was going to ask the difference between what is an SSRI versus an SNRI?
Sure. So an SSRI is a selective serotonin reuptake inhibitor. So that is basically the antidepressant which is sort of seen to have the least side effects. So it works on the neurotransmitter in your brain called serotonin. So you have like your neurons and then your synapse in the middle. What an SSRI does is when the serotonin is released from one neuron, it stops it being taken back up into the next one. So it's hanging about in your synapse, so it's boosting your serotonin levels, essentially. And SNRIs are noradrenaline and serotonin inhibitors. So they work on both noradrenaline and serotonin, basically. So yeah, that's the difference between them. So often if you tried an SSRI and that hadn't been effective, you might look at starting an SNRI.
So they're stronger, are they, the SNRIs to the SSRI?
They just work on two different neurotransmitters. So rather than just working on the serotonin, they're also working on the noradrenaline.
That's brilliant. Thank you. Does anyone else have a question?
Yeah, if you don't mind.
Yeah, go for it.
So I recently had a consultation with a patient, and they had described feelings of balling themselves up in the middle of the room and wanting to shut the world off completely. They're going through quite a heavy withdrawal at the moment from a quite potent medication. I think it's diazepam.
Okay.
And my recommendation to them, as I'm not a mental health professional, just hearing them out and recommending to call Samaritans when these feelings escalate. Is there a better practice I can put in place for that?
So are they so they're taking diazepam at the moment?
They're cutting down, so they're tapering.
They're reducing that, right? Okay. So and are they doing that with a sort of GP or a? Yeah. Okay. Yeah, it's really tricky. So benzos are really awful to come off of, particularly if people have been on them for a long time. Yeah, so kind of distress tolerance techniques as well. So things like making sure that you're kind of doing a self-care activity, using distraction, having a warm bath, things like that, but ringing somebody as well to talk that through. Do you ever signpost people to the 24/7 support and connect line?
So at the moment, I just signpost Samaritans with this particular patient because it's quite severe to the point where she is,
like having suicidal thoughts while that's happening.
No, just like balling up and wishing they could like kind of vanish from existence, like almost. So quite severe in my opinion, and because I'm not a professional, I give an open ear, but I don't feel it would be I don't think it would be worthwhile to start giving them anecdotal stuff of having tried having a bath or anything. I just
that's fine. If you don't feel comfortable to do that, that's totally fine. I would say there's a service in Bristol called Vitamines, which is the CBT sort of IAPT service. They have a 24/7 helpline, which is run by like a trained counsellor. So if it's that because they would be able to offer advice about kind of distress tolerance and management. So I can give you, I'm happy to share. I've got a list of different mental health crisis support numbers.
That would be brilliant. Thank you.
Yeah, shall I send that over to Vic? Are you happy to send that out, Vicky? Is that all right?
Yeah, that's fine.
Okay, lovely. Yeah, I'll send that through. What I would say is that they're services that are available in Bristol and we update them every year. So just to be aware that they might, like, to be checking them periodically to make sure they're still working. But yeah, I'll send all those through for you. That's absolutely fine.
Thank you.
No worries.
Has anyone else got another question? While everyone's thinking, Hilary, what about you talked about for ADHD, people, if they didn't want to go the NHS route, looking at right to choose. Do they have to pay for right to choose, or is that free?
No, so it's a free. It's an NHS service. So basically, because the waiting list was so long, sort of nationwide for an ADHD assessment, they've created this right to choose pathway. So Psychiatry UK is a private company, but they've got the NHS contract for right to choose. So they're still referred through their GP, and they do, it's free. They don't have to pay. The waiting list is just a bit shorter. Yeah.
Any other questions? I think that sounds like all the questions. That was really, really good. Thank you so much, Hilary, for that. A lot of information.
Yeah, no worries. You're welcome. Lovely to meet everybody, and I hope you all have a lovely day. And I'll send that list of numbers through for you now as well.
That'd be perfect. And can I, Hilary, is it all right if we forward your PowerPoint presentation to everybody?
Yeah, that's fine. It's got a load of references at the end as well. So if you wanted to go and have a look at something in a bit more detail, all the information's on there.
That's brilliant. Thank you very much, Hilary.
All right, lovely. Have a good day. Take care.
Take care. Bye. Right, that was brilliant. I thought that was really good. Does anyone have anything they would like to discuss? No? All I wanted to say is that we've got on the 11th of January, we've got confirmed up someone to talk about personal health budgets. So that's definitely going ahead. We're hoping to get someone on the 16th of November to talk about learning disabilities, but we've just still got to confirm up who that's going to be. And the other thing I was going to ask people is we haven't had many takers for the WhatsApp group. So if people are interested in joining the WhatsApp group about what's some advice from other people, it'll be sort of managed by ourselves with tips and things like that. If anyone needs any tips for anything, just send me your email, your telephone number to my email address, and then we can add you on. It's, obviously you can't mention patient names and things like that, but if it's just a little bit of advice, has anyone got a number for hoarding or something like that, then we can share bits and pieces with each other. Is that all right? Do people want me to go around everybody to see if they've got anything to say? I know I haven't heard from Maria. How are you, Maria?
Hi, yeah, we're good, thanks. Yeah, just plodding along, doing weird presentations for the kind of GP board yesterday and aging well and seeing patients. So yeah, just ticking along really. I think with the WhatsApp group, the only thing I would say is because we're all different, aren't we? We're all different disciplines. Would it be better to have groups that are specific to what we cover or just a general chat group? I don't know.
I think to start with, if we have lots of people interested, then obviously then we can split up. But to start with, I was thinking if we start and then see what the interests are and what the questions are. Sorry, Tracy, do you want to come in?
Yeah, no, it was just something different. I just wanted to recommend highly the Personalised Conversations, the health coach. I've learnt so much from that course. I just finished it this Monday. And the way that I talk to patients now has just grown and changed so much. I was a bit of a spoon feeder, but it really is a great course to do. It gives you, and it's the simplest of things. I know about open questions, but it's lots of other things that they involved. And one of the things they said at the end was, and I did it yesterday, there's a suicide awareness 20-minute online course as well, but it shows you when someone's, to use the word suicide, but, it was scenarios like there was a taxi driver and a young girl there, or there was, it just gave you real life scenarios. And then it talked to people that had tried to commit suicide and how they felt and how they want people to talk to them. It was an eye opener, and it's just 20 minutes. You get a little certificate as well.
Fantastic. Well, it'd be really interesting to see about the suicide course. If you could send me that, and then I'll send it out to everybody. Is that all right, Tracy?
Yeah, cool.
And with regards to the personalised health coaching, I know I'm desperate to get on it, but couldn't. I believe that we're going to have our own trainers in the new year. So come the new year, we should have a lot more availability for the health coaching one, which I think is what you've just done, Tracy.
Yeah.
And I know people are interested in health coaching too, but we need to try and get everyone through the health coaching one first, and then we will look to see how we can accommodate health coaching too. I know that's on the agenda, but obviously we're going to do the first one. If there's any other courses that you guys find that you're interested in, or something you need training on, obviously come back to us. Come sort of mid-December onwards, we're going to start sharing our training sessions with the social prescribers. So some months it may be more geared to the social prescribers, but it may be of interest to you. and sometimes it will be more what we want. So we're just going to have to wait and see how that works out. All right. So has anyone else got anything that they want to say? Sorry about that phone. Keris, how are you? I haven't seen you for a while.
Sorry, I've got a biscuit in my mouth.
I caught you.
Damn. Yeah, no, I'm good, thank you. How are you?
Yeah, really good, really good. You busy there?
Yeah, very. We're doing COVID, funnily enough. Huh?
What are you doing for COVID? Are you organising all the COVID vaccinations?
Yeah, everything. All the staffing. I'm
Yeah.
currently had 155 housebound patients to organise as well. So I've rung them all.
Wow, that's a lot.
Yep.
Fantastic. But you must be getting close to the end, because I know with our surgery we've done all the care homes for COVID and flu, and we're sort of nearly at the end of all the housebound.
Yeah, so we've luckily had MBT staff come in. It's just the organising of it. So we've got our last lot tomorrow. We've got our last 23 tomorrow, and that'll be it.
Oh, fantastic. And then are you going back to doing other things after that?
Hopefully. Yeah, we're looking at doing the NHS health checks, which would be really good, because I used to work in hospitals and take bloods and stuff. So that'd be really fun. Going back to our PPG, that'd be really nice. And then working on our care plans for our care homes. So
fantastic. Sounds like you're busy.
yeah,
Fantastic. John Morley. I don't think I've met you, John. Are you there? No, perhaps not. Katie, are you there?
Hiya, yeah, sort of a similar boat to Karis. We're doing COVID at the minute. I'm not doing as much as Karis, but still can't wait for it to be over.
Okay, it's not your favourite bit of it then?
Oh, absolutely not.
Oh, okay, cool. And Zoe, I can see you there, Zoe. What are you up to? I think you're just on mute at the moment. Oh, you haven't got a mic. Okay, so we'll have to do without. So hello, Zoe. Anyway, so I think that's probably, unless anyone wants to say anything else, I think that's probably all for this month. I'll continue to send out any updates I get or any new training bits and pieces. But Tracy, if you can pop on an email to me, that course, and I'll send it out to everyone.
Yeah,
and that would be fantastic. And catch up next month. Is that all right, everyone? All right, take care. See you soon.
Yes, bye.